So we will get started. Welcome. Good morning, everyone, and welcome to Managing Resistance. This is a dementia education program of Alzheimer's San Diego. My name is Amy Abrams, and I am the Director of Education here at Alzheimer's San Diego. Pleased to be presenting this webinar today. And with me is Brooke. Hi, Brooke.
Hi, everyone.
Brooke is a social worker, a member of our clinical services team, and will be with us throughout the webinar today, watching for questions that are popping up in the Q&A from you, responding to some of those questions in writing and holding some of them so that we can talk about them together during our verbal live Q&A breaks during the program here today. So thank you, Brooke, for being with us. She will also from time to time be sharing resources, links through the webinar chat. We'll get started on our agenda here today, Managing Resistance. This is one of our core caregiver skills programs. This is a part of the third in a three-part series on the topics of coping with personality and behavior changes, communication skills, and today, managing resistance. If you didn't take the first two, that's okay. They're all standalone programs, but they do all relate to each other pretty well. So I may reference one or more of those programs as we go along. Recordings of them are available in our webinar library. And again, these are core caregiver skills topics. We do teach these webinars live on a regular basis because they're so essential and foundational and skills that we all use every day as care partners to someone who's living with dementia. So here's our agenda for today. I'm going to talk briefly about dementia, the causes of resistance, what's going on in the different regions of the brain that causes people to resist our attempts at being helpful. We will talk about techniques for effective communication. Both of those segments are fairly brief, again, because we've got other programs devoted to those topics specifically, but we can't talk about responding to resistance without talking about why people with dementia are resistant and what we can do in our daily communications to mitigate, to make some of that a little bit easier. But then we'll spend some time talking about tips, practical tips on how to set up your room, your situation, your environment, your communication, whatever it might be, for helping somebody who resists your assistance, and then make sure that you know how and where to reach out for additional support if you need it. We are speaking today to people who care for someone living with dementia in a number of different capacities. We use the terms caregiver and care partner here interchangeably. Just people use different expressions to refer to that relationship. You may be a family member, you may be a friend, you may be local, you may live in the same home, or you may be hundreds of thousands of miles away from the person. So we are speaking to everyone. We are talking about all different kinds of resistance. But we know here at Alzheimer's San Diego, we know a lot of the questions we receive are about that kind of day-to-day stuff, helping somebody in the shower, helping somebody get dressed, dealing with somebody who refuses to eat or to take their medications, those types of issues. So that is what we're primarily focused on here today, but I hope that the concepts are broad enough that they'll apply in a variety of situations. On that note, I just want to say that we do our best to try to help you in our education programs. These webinars will try to address some of the specifics, but of course there's a lot of you and your specific situations. I can't know the details of, and again, that is what our clinical services team is here to help out with. So I'm here to give some foundational tools, general skills, and if you want to talk one-on-one about individual challenges that you're having, here's the setup in our shower, and here's what happens, right? When I try to do this, they do that. If you need that type of support, remember that our team is here to help with that. So let's start by talking about the causes of resistance in people who are living with dementia. And if you want to know more about Alzheimer's disease, the pathology, the progression, getting a diagnosis, the medications that are used to treat it, et cetera, I'd refer you to our Dementia 101 program. But for now, just to be really clear, the word dementia does not refer to any one medical condition. It refers to a syndrome, a group of symptoms that are caused by some medical condition. Often that cause is Alzheimer's disease, but there are many different types of dementia. Some are temporary and treatable and reversible. Most are not. Most are chronic and progressive, like Alzheimer's disease or vascular cognitive impairment or Lewy body dementia, for just as a few examples. So dementia is the word that we use to describe this cluster of symptoms that affect a person's memory, their language abilities, their general cognitive function, their ability to solve problems and reason, and changes to personality and behavior. Notably, dementia is present when a person is experiencing changes in two or more of these areas. It's not just a memory problem, for example. There's two or more domains, cognitive domains, that are affected, and the changes are significant enough that they're interfering with the person's normal level of function. So that's what dementia is. Just to clarify a couple of common misconceptions, dementia is not one specific disease, right? Again, Alzheimer's disease is a specific disease that causes the symptoms that we call dementia. Dementia is not a normal part of aging. Some memory changes, some physical and changes to visual spatial abilities, for example. Some of those changes, minimal changes, are normal and to be expected as we age. But the group of symptoms that we refer to as dementia is not a normal part of aging. It is due to the presence of disease. There is pathology in the brain, and it is absolutely beyond the person's control. This is probably obvious, but it's a very important concept, and it seems very easy to forget that in stressful moments, when it feels like the person is doing things just to be difficult, just to push our buttons. I just want to remind you that these changes, these are symptoms due to brain changes, and they are not within the person's control. So I like to draw the comparison between caregiving and sort of a day at the beach. I don't mean all the pleasantness that comes with the beach, but also sort of the hazards, right? Imagine yourself standing on the shore. You're maybe up to your knees or so in these ocean waves. Caring for a person with dementia can be a lot like that, right? There's a lot of good moments. There's moments of beauty and joy and peace and calm. But if you're not careful, right, if you're not watching, if you're not paying close attention, you can suddenly be kind of bowled over. You can get pulled under by the waves, by the challenges of caring for someone with dementia. Why is caring for someone with dementia so challenging, right? So a few of the reasons, and there's probably others, and feel free to in the chat if you want to share anything that I haven't covered here, feel free. But some of the things we recognize about why it's so difficult, their needs are always changing, right? There's good days and bad days, and you sort of have to daily, sometimes even hourly, kind of assess where is this person in terms of their function, their orientation, their mood. Where are we right now? The needs are always changing. And unfortunately, these conditions are mostly progressive. So they're not going to get better. While they'll have days, where they function higher, for the most part, over time, we can expect to see somebody lose function over time. That is a challenge for them and for us, right? Caregiving is physical work. If you are a hands-on caregiver, you know this well. It's tiring. It can be physically taxing. You can get hurt. It's actually pretty physically dangerous work in terms of slipping and hurting necks and shoulders and arms and backs, right? It's a physically demanding role. And on top of that, you're likely to have sleep disturbance because having disturbed sleep is a very common symptom of dementia. The sleep cycles are regulated by the brain. So if the person that you care for has disrupted sleep, then in all likelihood, you too have disrupted sleep. It can be a very isolating experience, hard for other people in your life to really understand and relate to all of these other challenges that you're dealing with. And if you're a long distance caregiver, I think sometimes people assume it's not that bad, right? At least you're not there, right? It can be, absolutely. It can be a huge challenge to be a long distance caregiver. And then there's all of the personality and behavior changes that come along with these conditions. So a lot of challenges, and then you add into that resistance, right? You're doing all of this work to keep up with their changing needs, to keep yourself strong and develop your skills, to try to stay socially active and connected, doing everything that you can as a well-meaning, well-intended care partner. And they say, no, thanks, right? Or they maybe don't say it quite so kindly, right? They resist your attempts to be helpful. Challenging, right? In moments of frustration, I find as a care partner, it can just be really helpful to remember this person is living with disease. So while this image is sometimes hard to look at, I think it's important that we try to remember this. We can't see this happening in their brain, right? But this is what's happening. This is just a graphic depiction of the type of tissue loss, of volume, of brain cell damage we see in people with advanced Alzheimer's disease. And if we could see this, right, day to day, I think it would be easier for us to remain more patient, more understanding, and more forgiving in those challenging moments. So let's take a very quick walk through what's going on in the brain, within these different regions, to talk about the damage that's happening and why we're seeing these different types of resistance. So when there's damage in the temporal lobes, these are sort of smack in the middle of our brains. These are the parts of our brain that primarily are involved in memory, specifically short-term memory, and a lot of our verbal language abilities. So somebody who is refusing an essential medication, for example, they may not remember that they need to take it. They may not remember why it was prescribed. And so they may have questions about, why do we need to do this? I'm not sure why I take this, or I think I don't take this, right? When there's damage up in the parietal lobes, up in the kind of crown of the head, this is where we'll see changes to a person's ability to perceive sensory information. Your eyes take in information, your ears take in sounds, your tongue takes in, these are your sensory organs, but it's this part of your brain that helps you make sense of what it is that you smell, taste, feel, right, through the surface of your skin, for example. This part of your brain is also heavily involved in your fine motor skill. So we lose dexterity when there's damage in this part of the brain. So this might explain that damage in this part of the brain might explain, for example, why somebody who on a very warm day wants to wear multiple layers of clothes. Right? We kind of think, well, it's so hot outside. Why on earth how could they be comfortable in this, right? It's not that people with dementia don't overheat, don't get hungry, right? Don't get thirsty. They feel all the same signals and discomforts, but their brain doesn't sort of give them the right message about why that's happening. So getting dressed, right? They might feel that need for layers and comfort because that feels good. It feels cozy, and not be able to interpret why that's making me feel so hot and uncomfortable, or not be able to sort of plan ahead and think, it's maybe not so hot yet, but it's going to be 20 degrees warmer this afternoon. I probably don't need an additional sweater here. When there's damage in the occipital lobe, this is toward the back of our brain. This is a part of our brain that's primarily involved in our vision, but also has a lot of significant role in our balance, our ability to sort of stay physically oriented to, we're upright or we're seated, and help us with balance. This is the part of our brain that when it is damaged, we'll start to see a significant narrowing of the person's field of vision, the sort of tunnel vision. And this doesn't just happen in the late stage of the disease. Even kind of early on, early middle stage dementia, we'll see people beginning to not be able to see their full environment around them. That has a lot to do with several different types of resistance. So somebody who's feeling anxious or fearful at bath time, for example, in the shower, if you just sort of come in, remember their balance may be off, their ability to perceive, that water is coming from this spout that's above my head, right? When it starts and when it starts falling, it can be scary and not make sense to them because they aren't seeing the full picture of what's happening in that bathtub or shower stall. So when people can't see what's going on in their periphery, or they can't make sense of it or process it quickly, it's very easy for us as care partners to startle them. And that will sort of start this cycle of fear and agitation, anxiety, and resistance. And finally, the big one, the boss, the frontal lobe. This is sometimes referred to as the CEO of our brains, the big region behind our forehead. And in particular, our prefrontal cortex. This is a very complex, a very smart part of our brain. This is the part of our brain that teenagers, it's not fully formed yet. We don't really finish developing our prefrontal cortex until we're in our early 20s, right, which explains a lot, I think. This is the part of our brain that helps us with decision making. It helps us with judgment. It helps us use insight and reason. Notably, it's also very heavily involved. Its function is required for us to have empathy for other people. Right. So when we see these personality, behavior changes, difficulty kind of regulating emotion, people just sort of act impulsively, say things, do things that are very out of character for them. That's usually due to changes to damage in that frontal lobe. So the types of resistance, the primary type of resistance that's related here is somebody who's just refusing your assistance because they don't really understand that they need your assistance, right? This is the part of your brain that would allow you to have insight. I'm really starting to struggle. My memory is really failing. I'm starting to need more help. I'm really glad this person is here to help me. Well, there's damage in the brain, in the part of the brain that helps them understand that, right? So they lack the insight. They don't know why you're trying to be helpful. Your attempts at being helpful are just, they feel oppressive. They don't understand it. And they don't understand why you are being so difficult, right? So I hope that little tour of the brain helps to kind of explain some of this stuff that we see in people who are living with dementia, why we see those personality and behavior changes in those folks that we know and love. So here's sort of the list of the common changes that we'll see: difficulty with decision-making, judgment, that agitation, that combativeness, difficulty initiating, starting and terminating or stopping tasks. This is really a really interesting symptom and something probably a lot of you have seen. Sometimes we sort of assume it's apathy or depression when somebody won't get up with us and go outside for a walk, for example, on a beautiful day, right? Often it's just having a really hard time with the planning, the sequencing, being able to think sort of abstractly about, what's outside, what's going to happen, what do I need to do next, right? Being able to think that through. Can be very difficult for people with dementia once they get started with something to stop it. So we'll start to see things like rummaging or, going through the cupboards, doing things repetitively. I had a family member who kind of pulled weeds, right? Picked at the grasses that grew in the spaces between the bricks. And sort of once he got started, he wasn't going to stop doing that, right? Just a really hard time knowing, all right, my back hurts, that's enough of this, right? Initiation and termination. Confabulation is a fancy word for something that all of our brains do. We make stuff up. We fill in the gaps, right? When we don't have complete information, our brains fill it in. So we sort of know the story and we can make sense of the world without knowing every single fact, every single thing, right? Well, there's a lot of gaps in the world of a person who's living with dementia, and their brains have to fill in a lot of space in the stories and the facts of a situation. So we often feel attacked. We feel defensive when somebody is saying we did something we didn't do or didn't do something that we did do. But please understand that, again, that is not something that the person is doing on purpose. That is their brain telling them a story. It's hard for them to make sense of, what parts of that are real, what parts of it are not. That often leads to suspicious and paranoid behavior, unfortunately, right? Because again, if my belongings aren't where I think they are supposed to be this morning when I wake up, my brain's going to confabulate that, right? It's not going to say, remember, I've got damage in that frontal lobe. My brain is probably not going to say, well, Amy, your memory has been slipping lately and you do seem to be losing things more often. I bet you put this somewhere and now you just can't remember where that was. It's not something my brain is likely to be able to tell me, to help me think through. Instead, I'm going to suspect the people in the house with me, right? The people who are closest to me. Somebody took my things, somebody is moving my things, for example. So again, it comes back to that limited insight into one's own care needs. We have a fancy word for this. It's called anosognosia, a lack of insight, a lack of awareness of one's own disability. And it's very common in people with dementia. And it's really important that we understand it when we are encountering resistance, which is, of course, chief among these personality and behavior changes that we see. So, Brooke, I'm going to pause here. Are there any questions on brain changes and the causes of resistance?
So we have a couple questions here, and they're actually related to what you just said about anosognosia, or that lack of insight. Just kind of a couple people saying the person is in denial and not sure how to help them or how to even talk to them about the memory loss. So that might be something you cover in a little bit, but those are what the questions are right now, of kind of how to handle that.
Okay, great. Well, first I'll just refer you back to our communication skills class, because we do talk quite a lot about anosognosia, refusal to acknowledge, denial. We talk about that in communication skills, but to respond to it, because it is an important type of resistance people struggle with, it's really important that we recognize they may not have that ability to have that insight. Most of the time, when we're encountering something that looks like denial, refusal to talk about this, I can't even say the word Alzheimer's, or it causes this person to get very angry. We just have to recognize that they aren't seeing those changes that you are seeing, right? It often feels, I often say this, when we're interacting with somebody who's living with dementia, we can frequently feel like we're just in two different worlds, right? We are not seeing things the same way. There's all these new dings in the car, and he doesn't seem to understand that him getting in these little accidents are what are causing those dings, right? But if he doesn't remember that he's had any of those little accidents, if they're not remembering what they don't remember, you can't really have a productive conversation, right, about the memory loss. So what you need to do instead is sort of change your goal, change your messaging a little bit. You're not going to be able to convince the person that they have Alzheimer's or dementia, or that they have even just a memory problem. What you're going to need to do is just sort of change their perspective on the help that you are providing. So if it's somebody who can't drive anymore, we just need to get them to think differently about the fact that someone else is going to start doing the driving now. We're not going to reach a point where we're going to convince this person that they need to stop driving, for example. Yeah, great questions. You good?
Yeah.
Okay, great. Well, we'll keep moving. We will be pausing again in a little bit here to there we go, to cover any more questions that you have. So please feel free to keep asking them as questions are coming up for you. You don't have to wait until the break. Just type them in, and we will respond as we go. So let's talk now a little bit about communication. So resistance is the word that we use to describe all these different things, right? It means different things to each of us, and each person with dementia sort of manifests resistance in a different way. But generally, it sort of looks like these things. Apathy, oh, it's such a beautiful day, let's get outside. No, thanks. Right. You haven't had a shower in a few days. Why don't I get the water started? No, I'm good. Maybe tomorrow. Right. Apathy is, I guess, the least dramatic of the types of resistance, but it's really frustrating to a caregiver. There's also arguing, so fighting with you, right? Or telling you, you're remembering wrong. I did already take my medication. I did take a shower yesterday. You've got the facts wrong. And it can be really, really hard. I use this image of the brick wall here, arguing with someone who's living with memory loss, confusion, disorientation, sensory processing changes related to those changes in their brain. Getting into an argument with someone who's experiencing those changes can feel a lot like talking to a wall, or sometimes kind of banging your head against a brick wall. Very, very frustrating. One of the most common types of resistance is refusing our help, right? This can be sort of passively just saying, no, thanks, I'm good, I've got it. Or it could be actively pushing you away if you're trying to provide some type of physical assistance. And sometimes it does come to combativeness, right? If we, it's not always our fault as caregivers, but often if we can't sort of stop the spiral of the anxiety, the agitation, the arguing, the confrontation, it will end up in physical combativeness or yelling. Sometimes it's physical, pushing, shoving, biting, spitting. We do see that happen from time to time. All of these different types of resistance are just different ways of saying no, right? I don't want to do that. I don't need to do that. I don't want your help with that. These are all just different ways of verbally or physically kind of putting up your hands and saying no. Why is it that it's so much easier for a person with dementia to say no to things than to say yes? If that's your experience, you are not alone. It's a very common thing. Do you feel like taking a shower? No. Do you feel like going for a walk? No, thanks, right? The answer to most questions to people who are mid-stage dementia or so is almost always no. And why is that? We have this little region in our brain called the amygdala. Among many other structures, this is sort of the one we focus on. I want to introduce you to this important part of the brain. It's a small region. It's deep in our brain. It's a very old part of our brain, meaning this is sort of from an evolutionary perspective, this is the part of your brain, of their brain that initiates fight or flight responses, right? That acts quickly to get you out of a situation or to help you flee a situation or to help you fight against a situation that is potentially dangerous to you. This part of our brain forms very early as children, and this part of our brain resists the damage of dementia. For most people, well into the disease, they've got a very healthy, fully functioning amygdala. So this explains a lot of the resistance, the combativeness, all of those different forms of resistance that I just introduced you to. This is what it's all about. This part of their brain is still working. It's kind of a positive way to look at it, if you will, if you can step away and kind of separate yourself from it. When we say yes to somebody, yes, I feel like having lunch right now. Yes, I think this would be a good time to get into the bath. When we say yes to somebody, we are making ourselves very vulnerable, right? We're opening ourselves up to whatever's going to come next. If it's taking a bath, it means, taking the clothes off and maybe getting cold before we get into the water. If it's going for a walk, it means going outside. And depending on where the person is in their disease process, they may not know what to expect out there. right? So saying no is a way of keeping ourselves from that vulnerability. If I just say no to whatever question you ask me, and keep in mind, this is not usually a conscious choice, right? This is just the brain firing off a quick response. If I say no to whatever it is you're asking or inviting me to do, I'm going to keep myself safe. I'm not going to be confronted by a situation where I won't know what to do, or I might potentially be uncomfortable, or something bad might happen. It's our way of keeping ourselves safe. So I hope that explains some of those different types of resistance that we see. So I just spent a lot of time talking you through what's going on in their brain, what's making them do this. And I want to also just take a moment and get you thinking about what is going on in your own brain. You have an amygdala too, and it's also probably pretty healthy and working quickly. It's strong, it's reactive, it's there to keep you safe too. Right? So when you are confronted by that brick wall, when you are confronted by the no, apathy, an argument, combativeness, no thanks, or somebody accusing you, not going to take that medication. I'm not going to let you poison me. Right? When you hear things like that, your defenses go up too. Right? That's very natural and that's very normal. And again, I'll kind of reframe that and say, yay for our working brains that are keeping us safe, protecting us from those things that make us vulnerable. But do recognize that that when your amygdala fires, and it's fast, right? These are our instincts. This is a physical gut reaction, right? That's where that comes from. When that's happening, you're probably not using your best judgment, right? You're being reactive rather than responsive. So what I want you to do when you're faced with resistance, when you're faced with a no thanks, or get the what out of here, right? When you are faced with that confrontational moment that makes you sad, that makes you angry, that gets you frustrated, I'll ask you to take a deep breath, right? Kind of go back to remember the power of that wave. Don't get sucked under here, right? Taking a deep breath, and in fact, taking about 3 deep breaths gives you the time you need to kind of reset, to not let your amygdala control, or that whole system, to not let it control your reaction to this person, to that moment, to that resistance. Take a deep breath, take a few of them. And what you do is you give that smarter prefrontal cortex part of your brain a moment to kind of catch up and think, what can I do here that's going to be a more helpful response to this situation than a pure reaction? Right? If you spend any time in the ocean or near the ocean, one of the things that most of us who surf or body surf or just like to swim in the waves, what we come to understand is that when a big wave is coming at you, what you don't want to do is stand firm and resist it, right? It is stronger than you. What you want to do is dive in, right? You want to let that wave kind of wash over you. So I like that analogy for responding to resistance rather than reacting to it. Dive in, right? Join it. Let yourself become kind of part of the power of that wave rather than letting it crash into you and kind of knock you over. So what do I mean by that? What is the difference between reacting and responding? Right? Ultimately, reacting is when we know you've got it wrong. You have not taken a shower in a week, right? When we correct, when we confront somebody, when we argue with them about the facts. Responding is when we're not getting hung up on the facts of this situation. We're not getting stuck on the words. We are responding to their feelings, right? We're validating. I know showers suck, right? It's cold. We'll just get this over with quick, right? You're validating whatever they're feeling, why ever they're resisting, whatever they're resisting. It's okay. They are allowed to have that feeling. Validating, providing reassurance, and ultimately redirecting their attention somewhere else. So it's about your focus, right? When you're reacting to someone, you're focusing on yourself. You're doing most of the talking. When you're responding to someone, it requires that you do more listening or watching if the person isn't very conversational. So a few very brief communication techniques. Try to maintain a calm and reassuring tone. And again, I do understand in those moments of stress and anger and defensiveness, this can be real hard to do. So go back to that time out, right? Take a deep breath. That will allow you to take sort of slow it down, calm down your tone and say something that's reassuring. I can see that you're upset, right? Use short, clear directions, limit the number of choices that you're asking a person to make. If you're giving instructions, try to give those instructions one step at a time, right? Give lots of time. We don't want to rush our way through communication or rush our way through our attempt to be helpful to somebody, right? We need to eat. We're trying, somebody who's resistant to eating, the last thing we want to do is try to rush them through a meal, right? Rush them through getting dressed, slow it all down. Give yourself plenty, give them lots of time, but give yourself plenty of time too. This is maybe one of the hardest habits for us to break as caregivers. We have a lot to do. We have a lot to try to get done in a day. So this is where learning to rely on your support system to offload what you can, right? Maybe if I have a little less else, a few fewer things on my to-do list, then I can slow things down and give her the full hour that she needs to get dressed and ready in the morning, right? And a really hard thing to do, I understand that, but can really help with overcoming a person's resistance if they can see we're not in a big hurry, we're not rushing them. Right? Repeating ourselves. When somebody doesn't understand what we say, we tend to say it again, but we say it a little differently. We add more information or we add urgency, right? Or irritation. You're not listening to me. I really need you to do this thing. Try to, again, catch yourself, repeat what you said and repeat it exactly the same way. Repeat it in the same tone. Don't repeat it as though you're saying it for the second or third time, even if you are, right? Because that irritation, that impatience, or that, don't you remember, we just talked about this, right? None of those things are helpful to that person in that moment. So doing what we can to validate, to agree with the person, hard to do, but we do have classes and techniques where we teach this. And one of the most effective strategies for validating somebody and for agreeing with someone is simply to apologize. This can be hard, right? We kind of have to swallow our pride a little bit here and sometimes apologize for things that totally aren't our fault, right? But I'm really sorry that came across that way, or I'm really sorry I messed that up. I was trying to help and I didn't do a good job there, right? Whatever the apology might be, that's a very powerful, but very simple tool for letting a person feel heard and understood, right? And maybe I don't even know why you're so mad right now. I can't in this moment figure out why you're resisting me, but I see that you are. I see you don't want to do this, right? Sometimes that's all they kind of need to hear from us. Right? So do your best to be forgiving of them, but also of yourself. You're not going to do this stuff perfectly. Don't take it personally, right? And don't expect perfection from yourself. One of the most important techniques I can teach you is not saying anything at all. When it comes to communicating, the most important thing for us to do is to listen and to watch, right? Of course, for long distance caregivers, this is harder. You're sometimes kind of listening for what you're not hearing, right? But certainly one of the most effective ways we have of communicating with other people, communicating to another person, is listening to them, observing them, watching them, letting them feel seen and heard and understood, right? So talking a little less, listening and watching a little bit more. So before we move on to some tips for providing help, I want to do a quick little poll with you to see if you've been paying attention. I'm going to go ahead and launch this poll. Hopefully you see it up there. Okay, hopefully you've got it there. This is anonymous. I won't know who answered, or who answered correctly or incorrectly. So go for it. Go freely. You can select multiple options if you like, but tell me which of these are ways of responding to what a person with dementia is expressing rather than reacting. Correcting, pointing out to the person, showing them when something is wrong, making it right, reassuring, reducing their worry or uncertainty, validating, affirming that the person is correct or that their feelings are valid, and confronting, challenging the person, trying to get them to get it right. Give you another minute here, a few more seconds here. Let me see, good number of you. Great. Okay, I'm going to go ahead and share the results. Hopefully you can see these, and 91% of you got the 2 correct answers. The ways of responding to someone, things that are not reactive, are being reassuring, saying or doing something to try to reduce the person's worry, recognizing that they may be uncertain about what's happening or what's going to happen next. And then validating that person, affirming that they are correct. This, I think, emotionally, this is a real tough one for most of us, agreeing with someone, even when you know that they've got the facts wrong, right? But remember that the way a person feels about a situation, the way a person feels about whether or not they should take their meds or whether or not they should let you help them wash their hair, the way they feel about it can't be wrong. We can't be incorrect in our feelings, right? So the person's feelings are valid. So thank you for participating in that. You are all been paying attention. I can see that. That's great to know. If that window, hopefully that poll window disappeared from your view. If it didn't, just click the little X and it should disappear and go out of your view. So now let's talk some practical tips for helping somebody who is being resistant. Okay. There we go. Okay, so some general guidelines. When we're providing care, again, it's important to remember that dementia causes a progressive loss of function. We are not trying to help a person with dementia learn a new skill or rehabilitate after an illness or an injury. Those are very common ways that most of us have been caregivers to someone else in the past, right? They had a stroke, they were sick with the flu, and we are helping them relearn how to do something or regain their strength or regain their abilities. Or if we've raised children, right? We are challenging them to develop new skills, right? This isn't what we're doing with a person with dementia. I'm not talking about giving up on them, right? Certainly, we want to push to what they can tolerate, right? But we're not pushing beyond that point. This isn't rehab, right? There is a difference there. Remembering that dementia does cause a progressive loss of function can help us kind of reset our thinking about the type of help we're trying to provide to them. Our goal in supporting somebody who's living with dementia is not to make them as independent as possible, right? Our goal is to help them feel as in control of their situation, as autonomous as possible. So if a person is losing the ability to sequence their way through getting dressed, for example, or taking a shower, right, they may want to do it all by themselves. We may, as somebody who loves them and cares about them, we may want to push them. Right? If I help her too much, she's going to become dependent on me. Right? That's not really our aim. Independence is not our aim in supporting somebody with a progressive loss of function due to dementia. But our goal should be to help that person while she's likely to lose the ability to dress herself over time. I want her to feel as in charge of how she's getting dressed, what she's wearing, right? She wants me out of her physical space. She doesn't want me helping. I want to help her feel as autonomous in this endeavor as possible. That's our goal. So try to keep that perspective in mind. As you can hopefully see, this is all about being flexible, about having reasonable expectations of them, but also of yourself. There's really only so much you can do. And sometimes you really do have to kind of raise the white flag, throw up your hands and say, okay, this isn't working today, right? This is not going to be a day I get him into the bath. So we don't want that to happen every day. We don't want that to happen for weeks on end, but it's okay, right? To sort of reset and say, I have to adjust my expectations for today. I had a client years ago who really struggled with getting his wife to bathe, shower, but she really loved swimming. She loved being in the pool. So on the days that showers and baths were just not happening, they got into bathing suits and they got into the hot tub, right? Not perfect, not a real clean, not terrific for her skin over time, but on those hard days, that worked. Right. So being flexible and being reasonable in your expectations. And this is far and away the most important tip I can give you. This comes to us from the occupational therapist, Teepa Snow, who you may be familiar with, who developed and teaches a method called the positive approach to care that helps us understand different ways of doing things with a person, joining them in the motion, in the movement, in the activity, sitting down with them to eat the meal rather than popping the plate down in front of them and walking away, right? Doing things with the person, not getting in their space and doing things to them, or getting frustrated because this is taking too long. Here, I'll just do it for you, right? Hard temptations to resist, but really, really important. So in providing care to somebody who is resistant, do what we can to create a dementia-friendly environment, right? Set yourself up for success right from the beginning. Removing clutter, stuff that you don't need. You want to have the stuff that you do need. Have the space prepared with the essential items, but get rid of the other stuff. So if you're going into the bathroom to do oral hygiene, for example. If you're not going to also be washing the face, shaving, right, all those other things, remove those items from view. Right. So depending on the setup of your bathroom and your space, this could be more or less difficult. Maybe just have a basket nearby where you can toss things and just sort of get them out of view, get them out of the way temporarily. If you don't have the space to actually, clear those things away, put them in another cupboard, just move them out of view temporarily. So, but do have what you do need, right? This is especially important in a tricky endeavor like getting dressed or showering, where there's a lot of stuff. You got to have all the things out. You want to, if you're going to be washing hair and conditioning, you want all those things there. You want the warm towels, you want the washcloths, you want all of those things handy so that when you do sort of have that moment, you get them to agree to get into that shower. You don't then have to say, oh, wait, let me and run to go get organized and get those things ready. So be ready with those essential items, minimize distractions, remembering those changes in the person's parietal lobe and the occipital lobe that make it harder for them to interpret sounds they're hearing. Reflections in mirrors can be very confusing, disorienting to somebody living with dementia. If there's a lot of activity, if there's a loud television, music that is distracting, sometimes music is a really helpful tool, right? If it's relaxing or it helps get them into the rhythm of a movement. But if it's music that is agitating to them or distracting, or a loud television, for example, can make it harder to focus on the meal, for example, if you're trying to get the person to eat. So do what you can to minimize distractions, get the room sort of quiet, the area sort of set up and focused for them. They need comfortable seating, accessible seating that they can get in and out of, or that you are able to help them get in and out of. Remember, when you're creating this dementia-friendly environment, this includes space for you too, right? So you need to be able to move around freely and comfortably. And then setting up the space with good lighting, very, very important. Remember, again, those changes to the visual field and also just normal age-related changes make us all need more light, but especially people that are living with dementia, and they need light that's coming from multiple directions, not just very bright overhead light that creates, shadow, and puts your face in shadow, or creates movement on the floor. Remember that those movements, those shadows, can be distracting and confusing to them. So have adequate lighting, but also have some up lighting, right? Simple little inexpensive tap lights installed along the floor or along countertops can go a long way to improving their ability to see what's going on during an activity. And then remember that the comfort factors that they need. For many people, the temperature of a room is really important, especially when we're talking about things that are going to require somebody to undress or partially undress. The room needs to be warm enough. And in all likelihood, in order for the room to be warm enough for them during the activity, it's going to have to be kind of uncomfortably hot for you. That's just sort of a reality, right? So dress light or dress in layers so that you can have the room warmed up to a comfortable temperature before you start. Adjust my screen a little bit here. Okay, so some quick tips on bathing and showering. Gather those supplies that you need in advance. Get the room warm, get the room brightly lit, whatever it is that you think the person needs. Start some soothing music, whatever it might be. Do all of that in advance. When it comes to the language of talking about, it's time for you to take a bath. You haven't had a shower in a week, right? We tend to start getting kind of, what's the word there? We're directing them. We're making this sound like something that we're going to do to them rather than something that they're going to do, right? So consider the language that you use to describe the fact that it's time for a bath. Think about the way that you're framing that and see if you can't come up with a different, better way of saying that, right? Something like, your bath is ready. Right? It's shower time, or maybe even not saying anything at all, right? Getting them sort of walking and distracted, and suddenly we end up in the bathroom together, so that you're not kind of building up the anticipation and the anxiety around it. Right? Remember that we all have a need for dignity and privacy, and taking a bath, showering, toileting, doing these things in front of other people, no matter who they are, no matter how close of a relationship we have with them, how intimate of a relationship we have had with them throughout our lives. This is hard for people to cope with, right? Not having privacy in the shower, not having privacy at the toilet, right? So one of the strategies we can use, this sort of gets a little bit awkward, but really just give this a try if it's working. Sometimes people will start someone in the shower kind of partially dressed, right? Still in their underclothes, still in the underwear and bra, for example, or in a bathing suit, or in a light t-shirt, that long t-shirt that covers, most of their private areas. Use washcloths or towels that are going to get really wet. But doing what you can to sort of cover up those spaces to help the person sort of protect their modesty, their need for privacy, if possible. We have an interesting instinct when we're in wet, sticky clothes. We want to get them off. So sometimes, again, this is sort of a strange strategy, but remarkably effective. Get the person, if that helps, right? Get them in there with some clothes still on, then help them get them off when they're uncomfortable. It's going to help them sort of warm up to the idea of being naked or exposed in front of you. Okay, getting dressed. Let's talk about, here we want to have the space set up. You want to have the clothes. When I was talking about limiting a person's choices, limiting the amount of decisions that you're asking them to make, clothing is one of those things. Even people without cognitive impairment can really struggle with, trying to figure out what to wear, what's appropriate for what we're going to be doing today, for the weather outside. Right? There's a lot of decision making that goes into that. So choosing simple clothing that's easy for them to get on and off. There are adaptive clothing options if the person has a lot of difficulty with manual dexterity, but cognitively they still, are able to dress themselves. They're just struggling with the physical movements of it. Simplify the clothing, simplify the footwear. If you're going to be helping somebody who can physically dress themselves, they just have a hard time sort of thinking through what to wear, go ahead and choose for them. Just don't get into the debate, into the argument. We don't need to negotiate every little thing. Put the clothes out for them, lay them out in the order in which they will put them on, and help them get started. Remember the difficulty with initiation and termination that I talked about before. Sometimes all the person needs is, if you sort of physically show them how to get their arm in the first hole, right? Their brain's going to kick in and, oh yeah, they're going to remember how to do the next one. You start the button, have them help you along, as you're starting to do that first button, have them put their fingers on that button as well, right? Their old muscle memories, their old procedural memories may very well still be able to sort of activate, and they can take it from there, but they need the help in getting started. As with showering and toileting, important to respect the person's privacy, respect the person's dignity, right? Look away, leave the room if it's safe, if you can, whatever it is that you think the person might need. But remember, getting dressed is an intimate act, right? And we don't want to assume that because this is our spouse, our parent, somebody we've known for a very long time, that, well, I've seen this person undressed 100 different times, hundreds of different times. Remember that the act itself, having somebody else there kind of involved in your space can be uncomfortable. Provide simple directions whenever possible, relying primarily on visual cueing if we can. Now, this is harder if you're not physically with the person, of course, but being able to show the person, if you are doing the act of putting on a jacket, if you are leaning down and tying your own shoe, right, and showing them what it is that you want them to do, often that's going to help sort of cognitively kind of get things moving for them. So providing more in the way of visual cueing, physical cueing, right? Again, taking their hands and having them touch the button so that they can feel it. Visual and physical cueing for people with dementia is often much easier than being able to, listen to a set of verbal instructions and make sense of them and know what to do. Right, it's a very different thing for me to say, okay, now button up your shirt, right? Than for me to actually take, show the person my shirt, show them, and while I say it, to say now button up your shirt, right, and show them what it is that you're doing. So that visual and physical cueing can go a long way. Some tips for mealtime, a big problem for a lot of folks. Consider doing what you can to kind of honor routine and structure within the home, when they like to eat, what they like to eat, as much as possible, but also recognize those things are going to change. Absolutely. We get a lot of questions. The person that I care for, no longer likes a lot of the food that they used to like, or suddenly has a serious sweet tooth that they never had one before. Very, very common in many different types of dementia, by the way, the craving of sugar, wanting to put ketchup on everything, for example, or eating lots of fruit or sweets, very common. So what we want to do is sort of honor routines and personal preferences, and of course, the need for good nutrition as much as possible, but being flexible in how we're doing that, right? So consider the timing of meals, the schedule, how it works for them and how it works for you, and the coursing of meals, right? We in all things, in dealing with resistance, we want to simplify, right? So if we can serve things one thing at a time, if that's reasonable, right? You know whether or not that's reasonable in your setup. coursing a meal so that they're only getting one, it's not a plate full of all of the different things that you're asking them to eat, but they're getting just their salad, or they're getting just their soup, or just their sandwich. And then the veggies are going to come later, for example. But consider carefully sort of what you know about this person and their preferences, and also weigh it with what's reasonable. Again, setting reasonable expectations for yourself as well as for them. Utensils can be really hard for people with dementia to manage. Remember those changes in the parietal lobe that I was talking about. So there comes a time in most disease processes when we have to start moving toward finger foods, or turning things that aren't finger food into finger food, right? Salad could be a finger food if you don't put a bunch of sticky dressing on it, right? So again, go back to that concept of flexibility. Right? Finger foods can make mealtime a lot less frustrating for both of you. If you're eating out, right? Think about going to restaurants where the staff are patient and friendly, and won't mind if the person is eating, you're breaking up their sandwich into little pieces, or they're eating a salad with their hands. Right? We're letting go of our sort of old conventions in the name of going along and getting along here. Right. Again, providing simple directions, one step at a time, providing as much visual cueing and physical cueing as you can, rather than just setting down the meal and saying, time to eat. Right. Instead, you sit down too. You have a plate in front of you as well. And you eat together. You're providing that visual cue, you lifting the fork, you taking the sips of water, whatever it might be. Keeping someone hydrated during the day is a big challenge too. It's one thing to just tell a person to drink water, but if you get a glass as well, you both get your bottles, you both get your tumblers out, and it's something that you're doing together, you're much more likely to get them to go along with you, because they can see what you're doing, right? And it sort of prompts them to take that same action. Eating is an inherently social activity. For most of us, we eat meals, right? If we live with other people, we're used to eating our meals with another person. And that's something we very easily forget as caregivers, right? Because maybe they eat differently now than they used to. They eat at a different time of day. You're not quite hungry yet, right? The schedules are all off. They're eating different food because of, chewing or swallowing problems, for example, or again, their tastes have changed. So you're just not eating the same meal. So it's very easy to fall out of the rhythm, the routine of eating together, but really important that we try to continue to make meals social. So even if you're not hungry yet, sit down with something, right? And sort of go through the motions. So this feels like something that we're doing together. Medication management. I actually have a short video I'm going to show you about this issue in particular. Very important and very challenging for a lot of people. So a couple kind of just practical places to start. Give the most important medications first. Talk to your pharmacist. There's a lot of ways that a good pharmacist can help you think through a lot of these problems, right? Pills that can't be crushed, that can't be broken in half, or that can't be put into food so that you could administer them more easily, right? Is there a different medication we could try that could be dosed differently, a different version of this pill, right? That isn't, for example, extended release. So it is okay if we crush it, for example. Talk to your pharmacist about which medications are the most important. Start with those, because sometimes you'll get the person to take one or two, but after that, they're not going to do anymore, right? So start with the most important ones. Talk with the pharmacist about, the person I care for functions best in the late morning or the early afternoon, or they're really wide awake at night. It would really help if I could administer medications at this particular time of day. What can we do, right, to change dosing or to change the setup a little bit? It's remarkable how helpful a pharmacist can be in these situations, and we tend to overlook them as a resource. So ask them about the necessity of medications, right? Don't be forcing these things down if they don't need to be taking them, the dosing, the time of day, and is there an alternative format that might be helpful? Okay, so I'm going to show you this short video, and the quality of it is better than what you see on screen here, I promise. This is part of UCLA's Alzheimer's and Dementia Care Program. They have a whole library of caregiver training videos on a variety of different topics that I hope you'll visit, and that will be helpful to you. I'm going to show you just one here.
Grandma hates taking her medicine, even after I tell her what it's for. She asks 10 different times why she's taking it. What should I do? Time to take your medicine, Grandma.
I don't need to take medicine. Who said I have to take that medicine? For what?
What are you talking about, Grandma? You have high blood pressure and diabetes. Dr. Brown said if you don't take your medicine, you're going to get sick.
I don't need pills.
Why do we have to do this every day? Just take your pills. I give up.
Refusal to take medication is a common manifestation of dementia. It can be very frustrating for the family, particularly as this has to be done every day. Stay calm and be patient, keeping in mind that these medications help your loved one stay healthy.
Time to take your medicine, Grandma.
I don't need to take medicine. Who said I have to take medicine? For what?
Remember, Dr. Brown said you have to take medicine for your blood pressure and your diabetes. He even wrote a note. My patient, Aura Jackson, that's you, needs to take her blood pressure and diabetes medicine every day. So let's take your medicine for Dr. Brown.
Okay, I'll take it today, but maybe not tomorrow. Only because Dr. Brown said it's a good idea.
Okay. Oh, I have an idea. Let's take the dogs outside for a walk. It's a beautiful day.
Do not allow your annoyance or frustration to become part of the problem. Your loved one may pick up on your emotions and become annoyed with herself or you. Here are a few tips on how to improve the situation. Pick a doctor or an individual that she wants to please and tell her that this person advises her to take these medications. If swallowing pills is the issue, check with your pharmacy to see if the medications are available in liquid form. If not, consider crushing pills into applesauce or pudding to make them more palatable. Give pills one at a time with water. Sit next to your loved one when you try to offer them medications instead of over her. If she continues to refuse, allow her to calm down for several minutes, then try again. Remember to be patient, as this process may take several attempts. In regards to specific medications, prioritize the most important medications to be taken first.
Try to get that to advance. Sorry, there we go. Okay, so again, that is part of the UCLA's caregiver training video library. So I really recommend visiting that. Again, you'll get a copy of the slides that contains that link, so you can go directly to that. There's a whole variety of topics, but I'd love to hear from you in the chat. If you're open to it, go ahead and in the chat and select all panelists and attendees so we can all see your responses. What did you see differently in that the care partner did differently in the second video in that sequence? What was different? There it is. That's the most important difference that I see too. She sat down, right? In the first one, I don't know if you caught it. She also held her hand. Yeah, I caught that too. She's a saint, someone said. Yeah. She explained it differently, right? Yeah. She wasn't standing over her, leaning over her. You know, in the first scenario, it kind of looked like this is something I'm doing to you, right? Yeah, the oh, I love that. She showed the letter from the doctor, but maybe she even wrote it herself. Entirely possible. We're proponents here of the therapeutic fib, if that's what you need to do, right? Find what's motivating to them. Right. I would say about the doctor's note, that does require the grandmother in that situation had to be able to know who that doctor was, to remember that this is my longtime doctor. She had to care about what that doctor says and thinks, right? There's a lot riding on that, but if that works in your situation, right, do it differently. Yeah, her voice was warm. Yes, a very important difference. Right. One thing I notice is just her tone on the subject of being warm. You know, she doesn't come in to the second interaction ready for a fight, right? She in the first one, she's like, this is always so hard. Why do we always have to do this, right? She's coming in with a bad attitude. And let's be generous and fair to her. She's probably exhausted. She's probably been doing this for a long time. And she does get that resistance all the time. She does know what to expect, right? But the second time, maybe she took that deep breath and decided she was going to sort of start fresh. Something that I see that somebody wrote, she didn't react to the no. She paused and then continued. A very important difference in the second one. And even once she got her to agree to take the medication, she still said something kind of snippy, right? Well, I'll do it for him, right? Rather than, you know, and I think somebody that's working really hard to care for someone day in and day out, it'd be very easy to take that personally and be like, well, why won't you do it for me? You'll only do it for him, right? But she didn't react to that, right? She kind of didn't take the bait, took a deep breath and kept moving, didn't engage in the negotiation or the fight. This was just sort of something we're going to do. I see an interesting comment here. Blaming a third party is an old customer service technique. Yeah, that's a great way to put it. I like that. Yeah. Any other ideas about something that she might have tried differently? She might have done that you didn't see her do? Something I think about is she didn't mention the idea if her grandmother loves taking the dog for a walk, she could have said that earlier, right? Once we do this, then we'll get outside, right? That's kind of deal making, might not always be effective, but could be helpful. Yes, yes. One of my favorite therapeutic fibs is it's time to take our vitamins, right? Let's and also I think another thing she could have done is sit down with her own, you know, box of vitamins, or if she takes medication, she could take them at the same time. She could, you know, set up a little box of Skittles or grapes or raisins or something for herself, right? So that she can sit down and we're going to do this thing together. Yeah. Great. Well, thank you for your feedback. And again, I encourage you to visit that library and see the other topics that are there. So in summary, what we want to try to do is honor the person's, you know, unique preferences, their comfort needs, their own personal rituals and routines as much as possible. If somebody was always a nighttime showerer, but it works better for you to get them cleaned up in the morning, right? See what you can do to change the rhythm, the setup of your day so that you can, you know, maybe do minimal cleaning up and getting ready for the day in the morning when they're not as fresh and receptive and lucid and clear-minded, and that you can help them with showering and bathing in the evening if that's been their preference. Maybe you're tired in the evening and you don't have the energy for it by evening, right? Know your limits and your needs as well. So that might mean bringing in some outside help, right? Someone else who can help you with that. Consider the time of day when we're trying to do these things. If a person, you know, every time I try to give her medications at 4 o'clock, right? She is just closed up, won't even open her mouth for me, right? Consider that that might be a time of day that her energy dips or her agitation spikes or she's more disoriented, right? And consider whether or not you can change the time of day when this task needs to happen. As you pointed out after watching that video, lots of validation and reassurance can really help. Being warm, saying yes, showing somebody when they're doing a good job, right? Nodding, thanking them for their cooperation, whatever works, right? You know the type of communication that's going to make sense for them in that moment, right? Some people don't like sort of overly effusive, warm and fuzzies, right? And some people really do. So you know your person, but doing what we can to make our demands not sound like demands, right? It's time to take our pills. Let's try it this way rather than, ooh, you're messing that up. Here, let me do it for you. Let me show you how to do that, right? Using the language of doing things together, us. We are doing this thing, even if you're not going to be taking a shower, even if you don't need to get dressed, right? Whatever the thing might be, try to use the language of this is a thing that we are going to do together. I'm not coming in and forcing this on you and doing it to you or for you. So back to that all important advice, right? How do you do all this in a stressful moment? You take a deep breath, right? Give yourself a moment to kind of reset, think it through, think to yourself, what can I do that's going to be more of a response? What can I do to dive into this wave, right? Rather than letting it, being firm, being rigid, and letting it crash into me. Brooke, we pause here for any questions that have come in to the Q&A.
Yeah, a couple of them here. So you've talked a lot throughout this, kind of interspersed with the different examples about kind of physical cues and things like that. Can you talk a bit more? This person's asking about body language to use to kind of reduce that resistance. The person they're caring for can't verbally communicate, so they're trying to focus more on, the body language. How can they show the person that they're trying to help and get them to let the person help change their clothes or bathe or whatever else?
Yes, great. That's a terrific question. Body language and how you physically move around a person and how you physically approach and touch somebody is really, really important. This is a big topic. And I will say Teepa Snow, the occupational therapist who I referred to before, on her website, which is teepasnow.com. Brooke, could I maybe ask if you want to put that out in the chat? She teaches a method called the positive approach to care. You can find on her YouTube channel, you can find free videos that show what the positive approach, the positive physical approach is all about. But in the meantime, let me just give a couple quick pointers on this. Remember the changes to the person's field of vision. If verbal communication is not a tool you can rely on as heavily now as you used to, then consider the physical position of your body. Remember that you want to make sure they know you're in their space and that you're coming toward them before you start touching them, before you're right there in their sort of intimate personal space. So pause, right? When you're maybe 6 feet or so away. This is part of the positive physical approach. We pause before we move into their private space. We make a little wave of our hand. We do something to get their attention so they know we're there and they know we're coming. Right. So you can move in a variety of different ways, but make sure that you're staying within their field of vision. Sometimes remember, like imagine yourself right now sitting wherever you're sitting, wearing a set of goggles, a scuba mask or a ski mask that really limits your field of vision. And think about if somebody is standing directly in front of you, how close they look. Right? How intimidating that can be, someone that's moving right into your space like that. So try to remember what you look like to them, what your approach feels like to them. Maybe stand a little bit kind of off center so that you're not taking up their whole field of vision, right? Kind of turn your body such that they can see around you. Makes people feel safer, right? To be able to see around you. keep a warm and pleasant demeanor as much as you can. Here's where the deep breathing comes into play. Give yourself a break. You're not always going to be able to do this perfectly. If you're exhausted and tired and frustrated, it can be harder to look happy to see the person, but do what you can before you walk into the room to take that deep breath and reset and come in like the granddaughter did in that second video, right? Her voice, her demeanor, everything was different in her body language. She didn't sort of come in already ready for a fight and exhausted and frustrated and kind of standing too close and standing kind of over her. So I'd say just consider your relation and your physical position to the person. And even if they can't verbally communicate the way that they used to, remember, you can keep talking, right? Slow it down and keep it chatty and conversational and light, maybe telling little stories, but keeping your tone warm and pleasant can really help. Music also might be a helpful tool as well. Yeah. What else?
This other question is talking about her mother's bedroom is very cluttered. She tends to hoard things. So she's asking about kind of suggestions since she can't really make it a safer, dementia-friendly environment. Any suggestions for that?
Right. She's still managing to hoard. Yeah. Well, this is a tricky situation, and you might consider consulting with a professional organizer, a declutterer, to just get those things out of the house altogether, right? So that they don't move their way back into the bedroom. You know, a certain amount of clutter is okay if it's something that the person is used to and that they can navigate. But you do need to trust your instincts when it's creating fall hazards, trip hazards, fire hazards, or they wouldn't be able to get out quickly in a fire in an unsafe situation, then it absolutely is something that needs to be addressed. I would say do what you can to get her out of the house, because trying to get rid of things while she's still there, as you probably have realized, is not going to be helpful. Moving things, not just moving them to other rooms, but actually getting rid of them, putting them in a garage or storage, or giving them away if that's possible. It sort of depends on the nature of the stuff and how much legal and financial authority you have there. But it is important to it might be a sort of constant cycle. There are a lot of people that do this sort of every day. While my loved one goes to her adult day program, I go in there and I get rid of 10 things, right? So that's not this big sudden change that she comes back and doesn't recognize her room. It looks so different, right? But just sort of slowly, a few things at a time, they're disappearing. Yeah. Give us a call. A member of our clinical services team might be able to give you some more personalized strategies on that. Yeah. Okay. Well, I think we're pretty close to our time here. So I'm sure there's still more questions, but Brooke will be sending out a link in the chat that you can use to request to have a member of our clinical services team follow up with you about a unique, an individual situation if you want to talk through. So let's wrap up by talking about some resources for additional support. And continuing with my analogy of those big, strong waves, we always recommend nobody swims alone, right? So we recommend that for you as well. Do what you can to keep learning, right? This is just the beginning. We have skills clinics recorded in our webinar library with the UCLA Library of Caregiver Training videos. Keep coming to classes, keep reading information. The more you know, right? We give you a lot of tips in these programs, and maybe there's one or two little things you can pull out and adapt to your situation. The more you hear, the more you're exposed to it, and the more you practice, the better you'll get at this. You'll develop your own strategies that work, and it helps us feel less anxious as caregivers, right? Just when we've got sort of more tools in the tool belt. right? Sometimes you need to educate other people too, because often and I hope you're not the only person involved in your loved one's care. Remember that other people who support you as a caregiver, other people that support the person living with dementia, need the education and the skill building as well. So find those community resources. We are a very good place to start. If we don't do it, we probably know someone who does. So get in touch with us at Alzheimer's San Diego if you have not already. Our clinical services team can connect you to respite, to more skill building opportunities, to support groups, to community resources like adult day programs or in-home care support, whatever it is that you might need, whatever it is you need to be able to get a break. That's what we've got to connect you with first, right? You can't be thoughtful, creative, patient, kind, forgiving, all these things I've suggested that you do. You can't do it if you're in this 24/7 and never getting an opportunity to clear your head and take those deep breaths. So if you don't have currently a supportive environment, a place where you can go to learn, where people are there that you can talk to about these day-to-day experiences, please get in touch with us. That is what we are here to do. Our team of dementia experts is available. We operate 32 different virtual support groups. They're all virtual right now, of course. Lots of online education offerings, both live and through our webinar library. We have some volunteer programs that I'll tell you more about here in a moment. We have our volunteers in touch who can make daily or regular telephone check-in calls to people with dementia who live alone. We have counseling sessions available with a licensed clinical social worker for care partners who are in need of some psychosocial support. We offer free social activities and outings, all online, or we do have things like our critter drive-in, visiting the Helen Woodward Animal Shelter for animal interactions, but from the safety of your car. So lots of different opportunities for connection and support here at Alzheimer's San Diego. In particular, I want to tell you about our virtual Alz Companions program, where we pair trained volunteers to be sort of virtual visitors to people with dementia who are living alone. Keep them company for a little while, do an activity together online, or just chat via, this is all, of course, virtual right now. Chat for a little while, let that care partner sort of off the hook for a time, give them a mental break so that they can go take care of something, or just take a mental holiday for a few minutes and do something that feeds their own soul. Perry, actually, our volunteer who's with us here today, is one of our virtual Alz Companions and has been a wonderful friend to one of our local families for a long time. It's a terrific program that gives socialization to people that are living with dementia, and the time and respite to care partners. And of course, we can help with the technology setup. If that's an obstacle, let us know. We can support you in figuring out how to get that all set up. So lots of ways to reach us through our website. You can email us, you can call us, you can even live chat us from the homepage of our website. Or again, Brooke is or has sent out the follow-up request form. If you have a question that we weren't able to get to here today, or you just want to know more about some of these community resources, go ahead and fill that out. And a member of our team will reach out and follow up with you on that. Or even if you don't know what you need, you just need somebody to reach out, that's fine too. Feel free to fill that out or reach out to us anytime. So a few upcoming education programs next week. We'll be doing a program that's open to people living with dementia and care partners on the topic of living with memory loss, sort of talking practical strategies for day-to-day living. And then we're going to be having our late stage series starting March 10th. So 2 programs, March 10th and 17th, one on caring for somebody in the late stage of the disease, and then preparing for a good end, talking about palliative care, hospice care, death care, doing what you can now to sort of think ahead and plan ahead for a good end of life for the person that you're caring for. So all of those and all of our education programs, information about them is up on our website. So I'm going to go ahead and wrap up. We're a few minutes behind here. When the webinar ends, you'll be directed toward a survey. We'd love your feedback on the program. You will be getting an emailed version of the slides from today, and a recording of this program will be in our webinar library within a few days. So please let us know how else we can support you. Thank you for your patience today. If we weren't able to answer your specific questions, we are here to help. And we appreciate you being here. We appreciate all that you're doing for the folks that you're caring for. It is hard work. And in the face of that hard work, you're often met with without thanks, without gratitude. So we'll give you some. Thank you for what you're doing. Let us know how we can support you in keeping strong and keeping going. So thank you.